Thank you. I've been tasked on this topic in part because our center has implemented embedded psychology and dietary management. It's challenging because the data are awfully thin. So I'm going to talk about the credibility gap on diet and IBD, the challenges of diet research in IBD and why we don't have much data, engaging patients on diet, and talking about eating during a flare and then helping patients return to a more broad diet, and evidence-based approaches, including nutritional deficiencies and symptom interventions. So why diet and IBD? Patients are deeply interested in the diet relationship to IBD. It's the #1 reason for calling the CCFA helpline. It's the top concern on Facebook chats run by CCFA, and patients are often looking for dietary advice. Patients clearly correlate changes in diet with food-related changes in symptoms, often without changes in disease activity, but they feel the difference. And they often go to the web where you can see flashing ads from this guy on the left, who I think of as the modern Rasputin. You also see people who look a little bit more legit, like Ginny Patel Thompson. If you want to frighten yourself, you can go to the Amazon link for this book and read the reviews and find out how many people are taking their children off of infliximab. Or a more reasonable approach like what to eat with IBD. But there are a lot of resources out there that are not evidence-based, and some of them are pretty out there. So food-related symptoms result in patients using rather extreme diets. There are many very popular ones on the web, including the specific carbohydrate diet, paleo diet, macaroon diet, which was really big in the 80s and seems to have faded along with the clothing, macrobiotic diets, and many of these restrict important nutrients. Many patients also spend lots of dollars on supplements which have pretty thin data, and we really need to prevent self-harm. There are possible mechanisms that actually make a lot of sense. You can reduce antigens. You're certainly putting less antigens into your gut immune system. Toxins are aggravating things. There's some evidence to suggest there may be benefit of the elemental diet, though it's awfully thin, and some evidence of reducing symptoms with defined diets. You can also clearly, with diet, alter the bacterial composition in the intestines, and you can think of food as the original prebiotic. Our microbiota share our food with us. And they also have been shown to alter gas production and fluid retention and can affect the dilatation of the small bowel, especially in people with strictures or narrowings or, for some reason, dysmotility from previous inflammation. There's also an entire subculture of the web with what I call challenges to authority, ads that start with one simple trick in some way or form. This guy, Kevin Trudeau, likes to say, "They don't want you to know." I'm not sure who they are, but I think I'm one of them. Denigrating Western medicine, very popular, and I have to say I'm very sorry. There is a group of patients in Western Michigan who are trying to convince the world that they need to travel to Peru and drink fog venom to cure their IBD. I didn't have anything to do with it. I'm just sorry. It's from my state. It happens frighteningly often. There are all kinds of websites promising a cure and selling some form of snake oil, and this at the bottom here is a picture of someone stewing a root in Peru, which supposedly you can combine with frog venom and have an intense ayahuasca hypnotic or hallucinogenic experience, which probably doesn't cure IBD, but people forget about it. It's been shown, and this is actually a nice paper from the American Journal of Gastroenterology, that ingestion of particular sugars can cause small bowel distension even in healthy patients. Drinking liquids containing defined sugars, and then they image patients' small bowel water content afterward. And there are clear effects of sugars and fructans, basically small carbohydrate molecules that bacteria like and can generate a lot of metabolites, a lot of methane and hydrogen, and retain water in the small bowel and distend it. Then there's a big credibility gap when you're sitting down with a patient and say, as far as we know, the evidence we have, diet does not affect inflammation in IBD. And the patient thinks, wow, I am so bloated and uncomfortable. This doctor's clearly an idiot who knows nothing about IBD. I'm going to go to the web and get that diet book. It's a big problem because we're talking inflammation and patients are talking about symptoms, and we have to meet them where they are. Patients find claims for macaroons, specific carbohydrate diet, which I found out was proposed as far back as 1924, actually for celiac disease and subsequently debunked, but it's hard for anything on the internet to die. The paleo diet, for some people, reason people think that internet entrepreneurs know a lot about diet. Mark Zuckerberg likes to kill what he eats. He also likes to form LLCs. I'm not sure why the paleo diet's such a good idea, but he likes it. Steve Jobs tried to cure pancreatic cancer with diet. Didn't work out so well, but people follow the fruitarian diet. And juicing is big for no apparent reason other than you can sell a lot of juicers. The outcomes of the credibility gap are that patients seek alternative therapies, diet cures, and they severely restrict their diets and nutrition. And patients, unfortunately, all too often stop effective anti-inflammatory therapies that have really good evidence. They spend their money on alternatives, and they can't afford the copays for effective medications. I had a patient about a year ago who started taking this giant canister of powder called Ultra Inflam X. He really liked the name and decided it was a good idea to stop his biologic at the same time. Didn't work out well, but it seemed attractive at the time to him. Patients are constantly seeking IBD diet information on the internet. The recommendations you can find on the internet have been documented well by Jason Ho and this paper from CGH. And recommendations say include fruits, avoid fruits, or internally conflicting information in the same article. Unfortunately, the data are all over the map because these actually aren't data. These are things that people are stating as opinions, and unfortunately, it's based on patient experience and not terribly helpful. If anything, there seems to be a trend towards avoiding dairy and nuts. Again, no data for that. Diet and risk in IBD, there's a lot of studies on this, looking at diet patterns prior to IBD diagnosis in terms of causation. There's some evidence that increased IBD risk is associated with Western diet, total fat, PUFA, fatty acids, omega-6, and meats, decreased risk with fiber and fruits, basically Western diet versus non-Western diet. There are a lot of theories that potentially you might affect inflammation with types of fatty acids in your diet, particularly Western diets and meats. Certain other fatty acids might decrease it. Again, these are in vitro studies or animal studies, not in humans, that have shown to be significant. And the downside is there's huge food avoidance in IBD. There's a high rate of food avoidance in IBD patients. In Jason's paper, he found across the board about 89% of Crohn's disease and 84% of ulcerative colitis patients avoid at least some food. In a poster yesterday, poster 89 at Cedars-Sinai, they found 40% of patients had at least 3 specific food avoidances. So they're restricting their diets in ways that are really unhealthy and can really cause significant malnutrition or at least deficiencies. It's very common to avoid dairy, gluten, vegetables, and red meat, and often poultry. A lot of low-protein diets out there. Both Crohn's and UC patients avoided nuts. And the statement is that I ate the food, I had an exacerbation, therefore they must be associated, and I'll never eat that food again. Great aversion therapy. Unfortunately, that connection isn't that solid, and you end up with people eating little or nothing. There are a lot of dietary deficiencies in IBD. This is from Guerrero's paper, basically showing that an enormous number of Crohn's disease patients are significantly deficient in many nutrients, including micronutrients. So it's a big issue over time, especially if patients are restricting their diets. 7% of hospitalized IBD patients meet criteria for severe protein calorie malnutrition. When this happens, it's associated with 3.5-fold increased mortality and associated with double length of stay and more than doubled hospital charges. So having a patient who is effectively choosing to get into this spiral can make their outcomes a lot worse. So in an IBD patient that's in clinical remission compared to controls, in general, IBD patients, even in remission, are going to have decreased body cell mass, decreased hand grip strength, and the effects are larger in patients with elevated CRP. And generally, a lot of it is decreased muscle mass. That decreased protein is a big deal. And over time, patients will often shift a lot of their muscle mass to fat, especially if they've been on steroids. So what's the evidence base? What can we do? What do we know about diet and IBD? So I did a Medline search in preparing for this talk for nutrition, randomized controlled trials on either UC or Crohn's. I found 99 publications. Of those, 11 were actually truly randomized controlled trials. None of those were positive, 0. It's really kind of frightening. And compared to the number of trials and medications, it's a drop in the bucket. So how good or bad are the data? The ones we have, typical example is an elemental diet, peptamen versus steroids in Crohn's. Only 22 patients enrolled, 2 weeks of treatment, no placebo control, possibly some benefit. The ESR decreased from 21 to 16, but not clinically meaningful, and certainly no endoscopy or other inflammatory markers. Another study of fructooligosaccharides, a prebiotic, they did get up to 103 patients. It was placebo-controlled, but there was no benefit. In fact, the dropout rate was a lot higher in the FOS arm compared to placebo due to increased bloating. And so prebiotics do feed the bacteria in the intestine. Unfortunately, it happened to make people feel worse. There is a lot of data, a lot of attempts at generating data at exclusive enteral nutrition. Unfortunately, it hasn't made a lot of headway in terms of helpful data. A Cochrane meta-analysis looked at 15 trials totaling 334 patients, so on average about 20 patients per study. Not very helpful. And they found it was less effective than steroids. There was no difference between elemental, non-elemental, or polymeric. Low fat equaled high fat, and the type of fat did not matter. They found it was not very effective in inducing remission. The quality of the evidence was very poor, and adherence was very poor. So really a problem in really advocating for EEN, especially when we have alternatives with strong evidence bases. And you might say, well, wait, I know pediatricians who use this. There are 0 prospective RCTs with mucosal healing endpoints for EEN, none. In contrast, anti-TNFs are proven in adults and children with multiple large RCTs with clear evidence of mucosal healing. So the evidence base for anti-TNFs is much stronger than EEN. And I think you really have to think about why are you not using the evidence-based therapy if you're thinking about EEN. But patients say, wait, but what about growth CD, a popular study? Again, not randomized, not blinded. But there was one study with healing in 34 patients. Again, not randomized, not blinded. But it probably improves the microbiota. Seems reasonable. One study actually showed the microbiota became less diverse with exclusive enteral nutrition. A proper RCT with objective endpoints is needed. Right now, anti-TNF is the standard of care because it has the best evidence base. Ideally, EEN should beat this or at least add to this. What is the evidence that adding it to the standard of care could improve outcomes? That would be great if it's true. There are studies in the design phase and hopefully underway soon to be determine this, but that's what we need. We need good evidence. So why is diet research in IBD so hard? Well, first you need RCTs with adequately large sample size, and that's hard. Patients have strong opinions about diet. They may not be willing to be randomized. It requires blinding, so you need a convincing placebo or sham diet that needs to be identical to the intervention diet in every way, including texture and taste, so that patients don't know the difference. They don't know what they're on. It's very difficult and very expensive. If you want to provide the full diet, so patients aren't cheating and they're really eating only the intervention, you have to replace all their food, including snacks, for the length of the study. It's very expensive, and it's really hard to keep patients from cheating. Even on EEN and patients in the hospital, more than 15% cheat. They snake down to the cafeteria. You have to provide interesting and tasty variety of food. It's, again, really expensive. And for supplements, if you're going to say, okay, I'm going to give you a supplement, I'm not going to replace your whole diet, the supplement you have to assume it's going to be so powerful that it will overwhelm the effects, the noise, of all the other food patients eat. And patients have repeatedly told us that all kinds of food changes their symptoms. They do better on some foods, worse on others. Think of all that noise in the background that you're trying to overpower with a supplement. People eat very diverse diets, so there's likely going to be a lot of noise, and you'll need much larger sample size. And your sham supplement, whatever it might be, has to be matched and very convincing, so patients don't know whether they're on the sham or the active supplement. The other problem is that there's no intellectual property. It's really hard to patent food. The only exception I know of is you can trademark a cake in Austria, and you can defend that with a lawsuit. And this is an example of the Sacher tort, where I was in Vienna last week. You can trademark a cake in Austria. But no one makes a profit if you can't protect your ideas, so there's no incentive to develop true evidence-based, FDA-approved nutritional therapy. It's really a difficult situation. Then there's the nutraceutical backdoor. Congress has fundamentally undermined the intent of the Pure Food and Drug Act with nutraceuticals. You can make unfounded medical claims about nutraceuticals or supplements or medical foods and get them promoted by paid celebrities like the great and wonderful Oz. There's no evidence-based or rigorous research needed, certainly not peer review, and definitely not FDA approval needed. Unfortunately, incentives align to get an appealing product on the Dr. Oz show and rake in profits without any evidence. So what can we do when we're facing patients with no evidence to speak of, at least not the rigorous evidence we would like, the kind of evidence we need to prescribe something like an anti-TNF? I think we have to engage patients on diet and differentiate between symptoms and control of inflammation and tell them we're going to try to treat both. We're going to encourage them to control symptoms with diet, but also control inflammation. We don't want patients to disengage and go to the web and find Rasputin and follow them down a strange and interesting path. So what you can and can't recommend? Well, we do have a smidgen of useful data. We know what doesn't work, and this is a classic example of a really well-done, rigorous trial with more than 700 patients, actually 2 RCTs, designed and run by Brian Fagan and Robarts, that showed that omega-3 fatty acids do not change the relapse rate in Crohn's. So you can tell your patients, omega-3 fatty acids, fish oil, forget about it. We've tested that. That one we actually have evidence on. Don't waste your money. But what do we have evidence for? Certainly treating nutritional deficiencies. Low iron, low vitamin D, vitamin B12 are all reasonable. I think it's helpful to engage patients on these and say, yes, I am thinking about your nutrition. I am monitoring. I can reassure you if these are normal or supplement when these are deficient. You can also recommend folate in patients on methotrexate or sulfasalazine. You can really guide people in monitoring their calories so they're meeting protein and caloric needs. It's hard to do sometimes with regular food if people have significant inflammation or bowel damage. And there may be a role for liquid supplements as long as patients can keep their costs low. These aren't therapies, these are supplements. There's really not evidence for a whole lot else. So we have paltry evidence on something that can change symptoms. Richard Geary did a study of low-fat diet on IBD symptoms. If you look at it in detail, it's a terrible study, actually. It's 52 Crohn's patients, 20 UC patients, no controls, no randomization, retrospective recall assessment of symptoms. Roughly 50% responded with improvement in overall abdominal symptoms, abdominal pain, bloating, passing gas, and diarrhea, but no evidence of change in inflammation. You could say, well, that's not good, but at least you have change in symptoms. And you can ask, is this good enough? Well, it is a bad study. There are no controls, no comparison diet, no prospective. It's not validated measure. It's basically a case series. But at least there's no evidence of harm, and it gives us a way to engage patients. And the reason I think about doing it, even though I'd really, really prefer to be evidence-based, is it allows me to regain credibility and recapture the patient from Rasputin, and this is the real Rasputin, by the way. And you're not doing EEN, you don't need an NG tube, and cost is low. And by treating symptoms, you can help the patient engage on inflammation. So which patients are likely to benefit from low FODMAPs? People with a history of bloating, distension, lots of gas, strictures, adhesions, slow motility, or lacking an IC valve, or a history of SIBO responsive to antibiotics. A few minutes about eating during flares and afterward. Most patients report that they benefit from restricting their diet during flares. Less input produces less output. Bland food, fewer symptoms. A liquid diet is often better tolerated. We tell them to limit caffeine as well as alcohol for less motility and decreased dehydration. But over time, what problematically happens is patients continue to restrict their diets even after inflammation is controlled, and you have to convince them to use more calories, maintain hydration during a flare, and not continue to restrict after their flare is treated. So you educate patients about flare, listen to their body, limit what gives them trouble. Often spicy foods or fats are common trouble areas. Liquids are often much better than solids in terms of tolerance. Avoid dehydration, not just water, but add salt, sugar, or rice, and suggest they use oral rehydration salts or something similar. If patients are having trouble getting protein and calories in, especially if they're losing weight quickly, I encourage them to use inexpensive supplements if they're tolerated. Simple things like over-the-counter breakfast essentials are easy. You may have to address lactose intolerance if they're lactose intolerant. You may have to have a more high caloric density with something like Nutrient 2.0. But ideally, return them to a full diet after the flare. You want to start slowly with small portions and get them over their fear of a particular food. It's bordering on PTSD. If they can take a small portion, they may be able to reintroduce that food. Eating with strictures is challenging. Generally, patients learn these very rapidly. They learn what causes blockages and vomiting. They want to have a low residue diet, avoid vegetables, fruits with skins, and soluble fiber. Lean protein is fine, pulp and skin-free fruit, and if they want to eat fiber, it has to be cooked and soft and preferably cut crossways, so they're short fibers, not long fibers. And I give them the example of celery. You don't cause it long ways, but crossways. It's important to achieve adequate protein and calorie intake. Often this will require a temporary liquid diet. Teach them about calorie and protein goals, especially when they're sick, because they're going to be higher, and help patients find a tolerable protein-calorie supplement and identify low-cost versions if possible. In terms of teaching patients about diet, I give them handouts about a flare diet, an obstructive low-residue diet, but I have dietitian involvement for a low FODMAP diet or low oxalate diet for renal stones. These are more complicated and hard to accomplish on their own. Why recommend restricting FODMAPs? About 30% of IBD patients meet Rome criteria for IBS. They have hypersensitivity. Many patients try expensive or fad diets. They spend a lot of money on supplements. And our goal is to prevent self-harm. And about 50% do benefit if they fit the criteria, especially if gas, bloating, or distension, or especially if abnormal anatomy from past surgery or bowel damage. Implementing this in the IBD clinic, if you have sufficient patient volume and interest, you have the right registered dietitians, preferably embedded in clinic at ours are, and the right payer mix. At this point, we mostly get coverage from Blue Cross Blue Shield. The remainder are basically self-pay. Typically, the dietitians see 3 to 4 new patients, 4 RVs per day. About 50% of ours are Blue Cross Blue Shield, some self-pay. And for an individual patient, the limit is 4 billable visits per year for Blue Cross Blue Shield. In terms of timeline, they start restriction of FODMAPs, do a diary review about 2 weeks later, and then try to, if they're responding, try to slowly reintroduce particular FODMAPs at low doses and see what they can tolerate and establish what their limit is. They also connect with patients through this Pinterest page, which Lauren uses, with low FODMAP foods. So in conclusion, I think it's really important to engage patients on diet, largely to prevent self-harm, even though our data, our evidence base is really quite weak. It's important to teach maintenance of protein and caloric needs, teach maintenance of hydration, use bland flare diets, but emphasize the importance of returning to a full diet, and use low FODMAP for selected patients and low residue for patients with obstruction. Thank you.